Urticaria is one of the common conditions that we usually encounter in day-to-day life, and it is usually associated with these transient lesions that appear on the skin, where the individual will report you that they have had an acute onset of these transient swellings on the body, which usually come and go over a short period of time, and they can recur and persist for over 6 months. My name is Dr. Abraham. So today we shall look at what causes urticaria and how do we go about it. So we can start this session today. So as you can see in this picture, usually in urticaria, we have what you call a primary lesion, which is called a wheal. So in this case, we define a wheal as a transient skin elevation or skin lesion that is due to edema and which results into swelling of the skin. So we put the word transient because it will be there for a short period of time, after which the skin will go back to its normal appearance. As you can see in this picture, in the first picture where my cursor is, so someone had a scratch on their skin, and then they ended up with this swelling, which was following the pattern of the scratch. And people have had this condition from time memorial, and you find some people actually boasting about it and then drawing particular shapes on their bodies to show others how bad they are. So like in this picture, as you can see here, someone did a tattoo-like drawing on the body to show you how the problem is. So everywhere it scratches or touches, they end up with these transient swellings on the body. So as you can see here in the last picture, this is the transient swelling that we have here, which can be that a transient papule if it is small, or a transient plaque. Sometimes it is annular, sometimes it is polycyclic, as you can see in this picture. So this is what we call urticaria. So moving forward, we define urticaria as a skin reaction characterized by appearance of wheals, as we've talked about, usually surrounded by a red halo, and associated symptoms include itching, stinging, and then pricking sensation. So the wheals that we see in urticaria are due to local edema, and as we've mentioned earlier, they can be annular or polycyclic in appearance. So angioedema, which is another type that we shall look at in the next video, we'll look at it as subcutaneous swelling, which may or may not be associated with wheals, and we shall look at the causes in the subsequent video. So the life prevalence of urticaria is slightly high. You may find that every individual in their lifetime, up to 8 to 22%, have had an episode of urticaria, whether due to insect bite, due to medication, due to allergens, or different causes like helminth infections. So at least in your lifetime, up to 22% of individuals experience this condition. So it's quite a little bit common. It was first described by Hippocrates in the 14th century before Christ, and the word urticaria is derived from a Latin word we call urtica, which simply means stinging nettle, and this is an insect that usually gives a reaction on the skin, which gives wheals, and that's where the word comes from. So when you are to look at how common is this condition, so urticaria is one of the most common conditions actually in dermatology, and it will be very hard for you to finish a day without maybe getting a patient or two with concerns of urticaria. So approximately, we say that 20% of people at one point in their lives experience this condition, and the acute forms or the acute types are commonly seen in children and young adults, whereas the chronic types are commonly seen in adults, and particularly more common in women. And this condition has no racial predilection, meaning that it occurs across the globe with no selection of maybe Black population or white population or the Caucasians. So this applies to all the populations in the world. So if you have to look at the causes, and if you have to break down the causes of urticaria, so urticaria has been shown to be due to various causes, including the first one being allergens. We have food allergens, including nuts, shellfish, and you've seen people reacting to food, like people even know the peanut allergy when someone is allergic to peanut, every time they take it, they can get this generalized body swellings, which can actually result into even anaphylaxis. Then they end up being either admitted or even as high as ending up in ICU. So you can also get allergens from sting bites like bee stings, wasp stings, and this at least we've encountered in our day-to-day life. And it can also lead you to allergens from medicines, including penicillins, aspirins. You've seen people getting urticaria lesions after starting a particular medicine that they're allergic to. So we've seen people who are allergic to sulfur, people who are allergic to penicillins, and every time they take a drug with that particular component, they end up with getting these urticaria lesions. Furthermore, it can also be caused by infections, especially hepatitis B and C, and then also bacterial infections like H. pylori and fungal infections. Some of them have been associated with urticaria lesions, as well as parasites, including the helminths, the Ascaris lumbricoids, the Trichinella and Schistosoma mansoni and the rest, all of them have been associated with urticaria lesions. And you'll find that at one point in life, maybe if you're a child, you had this experience where you had these transient lesions on the skin, and people thought actually maybe you had a parasitic infestation, and then they had to do deworming. So people have encountered this either knowingly or even unknowingly. Then we have other causes which we group as physical factors. These range from heat, cold, pressure, sun exposure, and vibration. So all these physical factors have been implicated in causes of urticaria. Then we have also other causes which are grouped as autoimmune conditions or autoimmune reactions, whereby your immune system starts to fight its own tissue, resulting into urticaria or transient welts on the body. So other things, including emotional stress and physical stress, can also exacerbate the symptoms, and other triggers including ingestants and inherents, e.g. grass pollen, foodstuffs, dust mite, drugs, insects. All these drugs and pollens and foodstuffs have also been shown to cause urticaria of different types. So when you look at the mechanisms of how you form this will or how it comes about, so you'll find that we say that in most of the cases, actually, despite knowing the things that we've listed above, most of the cases we are not able to identify the cause. So in most cases, urticaria tends to be idiopathic, and we don't know how it comes about. But then in some situations or scenarios, we have an immunological component whereby we have maybe an autoimmune disease or autoimmune antibodies that activate the IgE, the immunoglobulin A, that ends up activating mast cells, causing degranulation and then release of mast cell components, including histamines, the proteins and the different enzymes, and prostaglandins and the blood kinins, all which contribute to the vasodilation, with resulting into the welts that we see that present as urticaria. So we have also in other situations where you have different immune complexes that are deposited at the base of the blood vessels, triggering activation of the complement system. And at the end of it all, you have production of vasodilator chemokines that end up causing vasodilation and also damage to the vasculature. So in this case, you'll end up with a vasculitis of some sort, but presenting with urticaria lesions. Then we also have another component of the kinin system and complement dependent system, the C1 esterase inhibitor deficiency. So in this case, we know that every time you activate the complement system, you have at the end of it all regulate it by producing proteins that inhibit the process. One of those proteins include the C1 esterase inhibitor that sometimes tends to be deficient in some individuals. And at the end of it all, you end up with urticaria lesions because you cannot inhibit the process of kinin and complement pathway. Then the other etiologic mechanism, we classify them as the non-immunological. So in this case, you don't have a role of IgE or the immune complexes or the kinin or the complement system But then you have direct mast cell activation, which can be due to the trigger itself. So in this case, we have an example of opioids like morphine, which can directly activate the mast cells, causing degranulation of the mast cell granules and then releasing of the different vasoactive components. Then we can also have vasoactive stimuli, like from the nettle sting. We'll say that nettle sting is actually where the word urticaria comes from. In this case, the venom or the saliva from this insect directly stimulates the mast cells, causing degranulation. Then we have other drugs like the aspirins, the NSAIDs, which can also, in one or the other, to cause degranulation of the mast cells without necessarily going through the immunoglobulin E pathway or the immune complex pathway. Then we also have the angiotensin converting enzyme inhibitors, like the amlodipine and captopril. Those drugs usually they can also cause inhibition of the C1 esterase enzyme, and at the end of it all, you don't have regulation of the complement pathway. Then you end up with excessive vasodilatation, which presents with urticaria or even angioedema. So when you go to the pathomechanism, if you have to summarize it, in this case, you will have a stimuli, or sometimes you don't even have a stimuli, but you just have the drug acting directly on the mast cells, causing degranulation. Then after degranulation, you'll be able to produce histamine and other pro-inflammatory mediators, including different cytokines and activators of the complement. Then at the end of it all, because of histamine with its ability to cause vasodilatation, you have increased vasodilatation of the vasculature in that region where the stimulus has occurred. And the end effect of this is that you have increased permeability, so that allows extravasation of proteins as well as plasma fluid. So this one will leak into the surrounding intercellular spaces, and at the end of it all, then you have this swelling that will come in to give you those transient skin or mucosal swellings that we usually see in urticaria. So in summary, you have a stimuli causing mast cell degranulation. Then you'll have production of histamine, which is a vasodilator. After getting the vasodilatation, then you have extravasation of proteins, including albumin and immunoglobulins. At the end of it all, you'll have linkage of plasma into the surrounding tissue, which will give you that transient lesion. So what are the different types of urticaria? So urticaria, we usually classify it, one, whether is it idiopathic, which we call spontaneous, or we classify it as either physical, which is also called inducible. So inducible simply means that you can have a physical factor like heat or cold triggering urticaria, and in this case, the results are replicatable. So you can bring back the same trigger, then you get the same results of urticaria. But then in spontaneous urticaria, in that case, you don't have a known trigger, but it occurs. So spontaneous urticaria is further grouped, whether it is acute, if it has occurred to be less than 6 weeks, or if it is chronic, if it occurs for more than 6 weeks. So, and all this have been associated with different causes, including allergens, infections, and then also particular medications. And in this case, it may be key for you to identify where the trigger is, avoid the trigger, and then someone can get improvement, or they can get better. So when you look at urticaria, if it is inducible, we've said that in this case, you'll have physical factors that are causing the WHEALS. So this can further be categorized into demographism, androgenic, cold, heat, solar, physical, pressure, exercise-induced, cholinergic, vibratory, aquagenic, or even galvanic. So in this case, all these are just physical factors that induce urticaria. So if you are to classify it, still this is another table that I've put here to help us understand more. So you can have urticaria due to mechanical stimuli, which is also called physical. So in this case, you can have dermographism, which can either be immediate or even delayed. So in this case, you struck the skin of a patient with maybe a rough object. Then you wait, and within 5 minutes, then they have developed urticarial lesions. But sometimes it can even be delayed, which can occur later on, maybe after 30 minutes or so. And then they'll tell you that when I reached home where I had scratched or where I had stroked, the skin started to swell. So in that case, it will be delayed. But most of the times, this is a very common concern in people, but most of the times it is asymptomatic and people actually don't mind about it. Then we can have what we call delayed pressure urticaria. In this case, it can occur in areas of maybe the acute area, maybe after sitting for long, and it can also occur at the belt line. It can occur at areas of the undergarments after dressing them for a very long period of time. So when you remove them, because of the pressure that you have been applying there, or if maybe, for example, even if you just carried a very heavy backpack on your back, then you end up with swellings along the stripes of the back where the backpack was passing. We can also have vibratory. In this case, it can be either inherited or even acquired form. And in this case, you have vibratory angioedema. So it is very common in people who work with machines that usually vibrate, including the chainsaws, including the motorcycle, which usually have some degree of vibration. And in that case, the vibration is the trigger of the urticaria. Then urticaria can also be due to temperature changes. In this case, we can have heat urticaria or heat-induced urticaria, or we can also have cold-induced urticaria. So the heat-induced urticaria is usually the heat contact urticaria, and for the cold urticaria, it can either be primary or secondary. So in this case, it is primary if there's no, if it is pure the heat, the coldness that is triggering the urticaria, but it can be secondary in case someone has other paraprotein deficiency or like cryoprotein disorders that usually respond to cold, then resulting into development of urticaria. In that case, it will be secondary. Then we can also have urticaria, which is usually due to sweating or even stress. In this case, we can have cholinergic urticaria, allergic urticaria, or the exercised induced urticaria. That can be either due to heat, coldness, exercise, or even food being a trigger sometimes. Then you can also have contact urticaria, solar urticaria due to the sun, and then aquagenic urticaria due to water. So if you are to go one by one, when you look at dermographism, we say that someone will develop a local welt after stroking the skin. And in this case, we usually treat with antihistamine, but in case it persists and maybe someone is concerned, then you can do phototherapy. In this case, you'll give like 1 session per week and someone will have improvement. Then cholinergic, usually this is produced by the action of acetylcholine on mast cells. And in most of the time, it favors the face and the trunk. And it can persist for about 30 to 90 minutes. After that, the lesions will disappear. And usually, it's associated with increased core body temperature by 0.7 to 1 degrees Celsius. So in this case, what you have to remember is that for cholinergic urticaria, it favors the face and the trunk, triggered by acetylcholine. And usually in this case, the lesions will persist for about 30 to 90 minutes. And there's an increase in the core body temperature by 1 degree Celsius. Then for adrenergic urticaria, this is mediated by norepinephrine, and the treatment in this case, we usually give propranolol. For cold, someone has cold reactive proteins, the cryoproteins, and that would be primary, sorry, that would be secondary, but it can also be primary, whereby there is no protein disorders, but the cold itself directly stimulates urticaria. So for heat, someone will report that every time they maybe still go for a steam bath where the temperatures go above 43 degrees Celsius, then they develop these urticaria welts. So people who be in the desert, like in United Arab Emirates, where the temperature can even rise up to 51 degrees Celsius, the environmental temperature. So in this case, you'll end up having the heat-induced urticaria rashes on the skin. So when you go to the different types of physical urticaria more in details, we have solar urticaria, which is directly induced by the sunlight. And then in this case, the solution is to tell someone to do sun protection. This one can include putting on wide brim hats, putting on long sleeved clothes, or you can even get a shirt which has a sun protection factor. And then at the end of it all, you can as well put on sunscreen. This can be either chemical or physical sunscreens that help you to filter out the ultraviolet lights that usually trigger the solar urticaria. Then for pressure urticaria is also sometimes called the delayed pressure urticaria. Someone will develop pain and swelling usually 3 to 12 hours after the local pressure has been applied. As I told you earlier, in this case, maybe someone will put on a backpack and maybe for a trip or a journey, but then when they go home and remove the backpack later on in the evening, they realize that they have swelling along the stripes where the backpack was, or even sometimes people who drive long distances and then you're using a seat belt, so you end up developing welts along the area where the seat belt comes into contact with your body. Then for exercise-induced urticaria, in this case, it is thought that it is due to rise in body temperature that triggers this urticaria. And it is different from the cholinergic urticaria because in this case, the exercise-induced urticaria, usually someone develops larger wheals and they can be all over the body, as opposed to cholinergic urticaria, which favors the face and the upper trunk. Then the vibratory angioedema, we've seen this as occupational hazard, and in some mostly seen in people with occupations where they use vibrating machines like the chainsaw, like the motorcycles, the grinders. So all those machines that are usually vibrating, they can trigger this vibratory angioedema. Then for aquagenic urticaria, aqua means water. So in this case, it is triggered by water at any temperature. So there will be a difference between aquagenic pruritus and aquagenic urticaria. So for aquagenic urticaria, the temperature of the water does not matter. And that is different from aquagenic pruritus. So aquagenic pruritus will be for a particular temperature of water. So someone will tell you that if the temperature is very, maybe if the water is cold, they get the reaction, the itching. But if the water is hot, they don't get the itching. So that will be more of aquagenic pruritus. But aquagenic urticaria, they will get these urticarial lesions that are not determined by the temperature of the water. Then the last one that has been described is the galvanic urticaria, which is due to this metal, galvanic devices, and people have been reacting to this metal. So it's most commonly seen in industrial workers. So when you go to the laboratory investigations, how would you investigate urticaria? So depending on the type of urticaria, you would like to do particular investigations to make sure that if you're able to identify a particular trigger. So the chronic spontaneous urticaria, usually the positivity of any test is variable. Sometimes all the tests are negative, they don't mean anything, and then you just end up treating the patient to get rid of the condition, but without necessarily knowing the primary trigger, the primary cause. And for acute phase reactions, usually we can do ESR if someone has an acute onset, CRP, usually these ones are inflammatory protein markers, and the D-dimers as well. Then we can also screen them for thyroid function test and the anti-thyroid antibodies. So in this case, we've seen that sometimes the urticaria can be due to autoimmune conditions. So we have to screen to rule out autoimmune thyroiditis, which is one of the things that have been associated with urticarial lesions. Then you can do total IgE levels. So in this case, we know that in the pathomechanism of most of the urticaria, the immune mediator types is mediated by the IgE. So if you do total IgE, you'll be able to see the levels, then you can have an idea. Then we've known some infection to trigger urticaria, including hepatitis B and hepatitis C. So we have to screen for them. Then we know that sometimes helminths can also trigger urticaria. So you do a stool analysis. Then you want to do your baseline liver and renal function test plus a full blood count to rule out any other derangements in the organ function. Then you can also do tryptase screening if you suspect a systemic mastocytosis. So we shall have a session on mastocytosis, and then you'll get to know why we do the tryptase. So when you take off a biopsy of these arterial lesions, what do you see on histology? So in most of the time, you will say that you have these transient lesions that are basically due to edema being triggered by increased vasodilatation in the tissues. So even on histology, you'll see that most of the times, the changes are seen within the upper and the lower dermis. So what you'll see is the mild dermal edema, and you'll see the separation of collagen bundles with water, and then you'll see dilatation of the small blood vessels, because you said that histamine will cause vesicular dilatation, and then even the lymphocytes, if the lymphatics, sorry, will also be dilated, and then sometimes you'll have different cellular infiltrates depending on the trigger. You can have lymphocytes, eosinophils, if it's an allergic reactions. Sometimes you can have a neutrophil infiltrate, in some forms of physical urticarias. And then sometimes you can see neutrophils with the eosinophils occurring around the remains of blood vessels in urticaria lesions. And then you can also see these other lymphocytes as well around blood vessels. But most of the times, you will not be able to see any fibrin changes or any hemorrhage or any local leukocytoclasses. So in this case, so you see that like in this picture here, so this was a patient of urticaria. We took off a sample, and this is how it will look like. If you have to review the slide from up down, you see that the stratum corneum looks normal. The stratum granulosum is okay. The spinosum is okay. Then the basal layer is fine. Then literally the upper dermis also looks fine. But when you come down here in the lower dermis, you see that there's a lot of space in between the collagen fibers. So that is dermal edema. And in this case, in the close-up, you see these eosinophils, which are the cells that usually infiltrate the lesions in urticaria, but sometimes you can also see a few lymphocytes here. And this in this case, you just had abundant eosinophils. So the treatment ladder in urticaria, usually when you're treating urticaria, you need to follow particular steps. So depending on how the patient has presented. So you want to begin low, then you keep upgrading the dose until when you have control over the condition. So the first line, we give non-sedating H1 blockers or antihistamines. So we can give the cetirizine, we can give the loratadine. So you start with one tablet, and then you monitor maybe for 2 weeks. If there's no improvement, we usually increase the dose of that same drug. If you're starting at, for example, cetirizine at 10, you can now step it up maybe to 20. If there's no improvement, you step it up to 30. If there's no improvement, you go to the maximum dose, which is usually 40. So if someone has no improvement at the maximum dose of cetirizine, then you introduce a second H2 antihistamine, maybe together with a leukotriene receptor antagonist, or even mast cell stabilizers like montelukast. So if there is no improvement there, then you can now go to the biologicals, including omalizumab, which is a monoclonal antibody drug. So in this case, we usually use it for chronic urticaria if someone has no improvement. So with this, if still there's no improvement, we can still step up to the 5th line. In this case, you can use immune suppressants, including the cyclosporine, but this one is usually reserved for refractory cases, so people who are not improving. So what can complicate urticaria? So urticaria can complicate with angioedema, where you have now subcutaneous tissue swelling, which can even threaten airway, or which can result into airway compromise. Then you can also have anaphylaxis. This is a little bit rare, but in some cases, for people who are very sensitive and allergic, you can end up with systemic allergic reactions, which can end up actually even in ICU. Then for chronic urticaria, it is very, very significant to understand that it has an impact on the quality of life, and it can eventually lead to even anxiety and depression. So when you're managing it, you have to be a bit more aggressive because it disrupts someone's activity in day-to-day life. Thank you very much. See you in the next video.